Hello and welcome to the webinar. Thank you for joining us today. I am Cassidy Ovula at the Center for Optimizing Rural Health at Texas A&M University, and this is our monthly educational webinar. Our topic today is a pathway for rural health to thrive in a post-COVID-19 world, presented by Benjamin Anderson with the Colorado Hospital Association. I do have a few notes for you before we jump in. First, all participants are muted, but we do welcome and encourage questions. You may type them into the chat as they come to you or wait till the end of the presentation, but either way, we will address them at the end of the hour during our Q&A. And we are recording this webinar, and we will share the recording link as well as the slides on the core website and our YouTube channel with you in an email following this presentation. So now it is my pleasure to introduce our speaker, Mr. Benjamin Anderson. Benjamin is the Vice President of Rural Health and Hospitals for Colorado Hospital Association. He provides leadership and direction in the development and execution of the association's rural strategies, advocates on behalf of rural hospitals and health systems, and works to develop strategic partnerships with organizations that affect the health of rural Coloradans. Benjamin has 20 years of experience in healthcare and nonprofit administration and is a nationally recognized leader in health equity and transforming healthcare, rural healthcare through an initiative approaching, through an innovative approach to attracting physicians to diverse, underserved areas with a generous paid time off package to be used for international volunteer work. He is the co-principal investigator of a nationally released toolkit and playbook called Redefining Leadership, a pathway for rural health to thrive in a COVID-19 world. Prior to joining CHA, he spent 6 years serving as the CEO of Kearney County Hospital in Lakin, Kansas. Benjamin earned a Bachelor of Arts in English and an MBA from Drury University, as well as a Master's of Healthcare Delivery Science from Dartmouth College. Benjamin, we are thrilled to have you with us today. Welcome, and it is all yours.
Thanks for that kind introduction, everybody. I appreciate that. Making sure that my slides are working here. Are they advancing?
They're not. You may have to.
How about now?
Perfect.
We're in good shape. All right. Well, thank you again for the opportunity to be with you. I'm having a fun time just looking through the attendee list and seeing some friends on the list. I'm going to jump right in. I'm going to begin by sharing a few stories that are personal, and then we're gonna dive right into their implications or the implications of what's happened over the last 9 months on all of us. So I am the father. I'm the husband of a beautiful woman named Kayla Sue, and I'm the father of 4 young children who at the beginning of COVID were 7, 7, 5, and 5. They had all just had a birthday right when COVID had showed up. And so this is a picture of our 2 daughters. We have boy-girl sets of 7s and boy-girl sets of 5 that are now, of course, 8, 6, and 6. And these are our daughters, and they were in the front room of our house, and they had taken the character they call Stinky Pinky the pig and had arranged for a carriage to carry them through the front room. What you don't see probably in this picture, you see a bit of a mess, but what you don't see was that this was after 2 straight weeks of us being at home without ever leaving our house. This was back in March of 2020. And I'm working 18-hour days with the association, trying to ensure that hospitals get the resources they need so they don't close, because we haven't had rural hospital closures in Colorado and didn't want to start then. And so meanwhile, our 2 7s and 2 5s are climbing the walls, not leaving our small house for over 2 weeks, not even for groceries or to go to the park or anything. So we figured out after that 2 weeks that we'd hunkered down, that we had to do something. And my wife was born and raised on a small farm in Kansas, the town of Sabetha. And so we figured out that once we had quarantined for those 2 weeks, if we literally went in nowhere, went to no bathroom, did anything, we could get to Sabetha, Kansas, and their 160 acres and hunker down there and at least get them there for 6 weeks so they could run around. And so it's a simple farm, but a beautiful place. And so we got out there, and what I saw when we arrived was our daughter, 7-year-old girl, playing on the farm, playing on a makeshift zip line that her papa had created. Our other daughter climbing on the cattle guards or the fences that were at their house, playing down by a little creek or a crick, as they'd call it, playing down by this little marsh that's on their property. Um, Climbing on the fences, swinging on the tree swings, helping in the garden. And what I was able to see, and I remember sitting outside just in the first weekend as I was dropping them off, was uh, our daughter running through the windbreak at their house, because anybody that lives on the plains is familiar with the importance of a windbreak and this group of trees that blocks your house from the damage of the extreme wind on the plains. And I saw them running through this windbreak, our daughters, and I imagined the 8-year-old version of my wife, Kayla, growing up in that same place, um, playing with horses, being outside, having fun with her dad. And I was able to see my wife's childhood in a way that I had never been able to see it before. I grew up in the Bay Area in California, in a very diverse urban center. And my exposure to rural was really through my wife. And so I was able to see her childhood that she treasures so much through the eyes of our little girls as we were there. And then I was able to imagine her mom, who 30 years prior was a kid in that same 2 or 3 mile area of the United States, right near the center point of the US. And then I was able to imagine her grandmother the same way. And as I was thinking about that, as I saw our kids running through the windbreak, the words, "Oh, beautiful for spacious skies, for amber waves of grain, for purple mountain majesties above the fruited plain, America, America, God shed his grace on thee and crowned thy good with brotherhood from sea to shining sea." Elizabeth Ann Bates, a poet way ahead of her time, wrote those words in the song America, what became the song America the Beautiful. She wrote those words after touring rural America. And it occurred to me as I was sitting there, this is what we're fighting for. As we were worried about hospitals closing and health disparities between rural and urban Americans deepening, and the loss of access and its implications on maternity care, especially for people of color in the Southeast, women of color in the Southeast, just thinking about the implications there. I remember thinking this really is what we're fighting for. So I'm going to tell you now another story as we get into this, and it's about our 7-year-old daughter's twin brother, and his name is David. David loves to learn. We write letters and book reports to people around the country. So if you want a book report from an 8-year-old little boy, just stick your address in the chat. We'll probably mail you a book report that he's written. And usually people will mail him back some notes on his book report and give him $1. We send this to friends and family. And then when he gets the letter back, he puts a sticker with his color on our US map in our house. And he gets to learn about geography and learn about communication, learn about writing, and whatever he was reading about, he gets to learn about that. So David loves to learn. David loves to build. He likes to take things that don't go together and make them go together. He loves to play. This is us outside playing in the snow here in Denver. He loves sports like many little boys, and like almost all little boys, he loves to be outside. Much to his mother's chagrin, David loves the mud. And loves to traipse it into the house. He loves to work, and he especially loves to work for ice cream. His lifelong dream is to be a police officer, and he also wants to be a farmer like his papa. And he's funny. He has a soft and humble heart. He's teachable. And he loves his siblings. This is them when they just before COVID broke out at 7, 7, 5, and 5. He loves his mommy. And his favorite story, bedtime story, is the story of David and Goliath. So David, I'm not sure exactly. I mean, many or all of you are familiar with the story of the underdog, of David beating Goliath in a battle. And I'm not sure exactly why this story connects with him so much. It could be that his name is David, and the kid in the story is named David. It could be because it's about fighting and battle and war, and he's all about those things. He's a fighter. He's a lover and a fighter. But it could be that it's about an undersized kid that shows up with a handful of rocks at a sword fight, and he wins. And every night I go in there and I sing him this song, only the boy named David, only a little sling, only a boy named David, and he loves to play and sing, only a boy named David, only a bubbling brook, only a boy named David, and 5 little stones he took. And 1 little stone went into the sling, and the sling went around and around, and that little stone went high in the air, and the giant came tumbling down. And at the end of the story, he replays that back and forth for me, just play by play. This is how it went. This is as though I'd never heard this story before. He replays it for me. And one night, just when COVID was starting, he looked up at me from his bed when he was laying down and said, "Dad, did I beat Goliath?" And it took me a minute to realize what he was actually saying, which is, "Dad, could I beat Goliath?" Which is a profound question, because David had met his Goliath a few years prior when he was diagnosed with a rare form of epilepsy that would cause up to 60 seizures a day, that would affect his short-term memory, his cognitive function, his decision making, his hyperactivity. I mean, he had plenty of issues that were going on that would show up on an MRI. And so underneath the surface, there is this neurological difference, this issue that happened 36 weeks gestation, and we won't ever know what happened or why. David was adopted at birth, and so we won't know that stuff, but we know that it exists. And so on the inside, all that's going on, but on the outside, he looks like a happy, very good looking, highly energetic, poorly parented little boy that really just needs a consequence, because if you just parent your kid right, he wouldn't act like that, right? So it would lead to a significant series of challenges for David, that when we were at the time living in the 10th most remote town in the United States, according to the Washington Post, judged by driving distance to a city of 75,000 or more, we couldn't get access to the services that we need. We hopped on angel flights to go to the Mayo Clinic. We drove 4 hours one way for a doctor's appointment in Wichita. We exhausted everything I knew as a hospital CEO with knowledge of the industry to try to get him the services that he needed, but it was so challenging. And that eventually ended up leading us to Denver, because we didn't have the resources we needed to ensure that he would have as good a chance of a go as if we lived in Denver, Colorado. And so we moved here. And I will never forget a conversation with one of the board members on the hospital when I resigned. She was the parent of a special needs kiddo, and she ran an organization called Families Together that connected special needs families in rural areas with the resources they needed. But she said, "I understand and support your decision to move, but please know that there are about 40 million of us in the United States that can't just move. We're here. This is our reality. This is our home. This is our identity. This is our livelihood. These are our farms, and we're making food for the rest of America, and we still have to live here. And so please remember that." And so with that etched in my mind, I'm going to transition now to highlighting some of the reality of rural America, and then we're going to talk about what we can do about it. First, this is one of my closest professional mentors over the last decade as a CEO, a hospital CEO. And she was the president and CEO of SSM Healthcare, became later the board chair. She was the CEO when SSM won the first ever National Malcolm Baldrige Award for a healthcare organization. She's a relentless advocate for health equity. Before we called it health equity, a relentless advocate for justice, for quality. She has no tolerance for avoidable harm, and just really a firecracker of a person. And developed a friendship with her. And she and I are kind of unlikely friends with different backgrounds. But she, for whatever reason, started taking my calls and kept taking my calls and still takes my calls. And a lesson that she taught me that I hope I never forget and I want to share with you is that systems heal people, And systems harm or kill people, and developing good systems requires good strategy. This doesn't happen on accident. And so take that into the rest of this presentation or conversation, because that's what we're going to be talking about, are the structures and the capacities that lead to healing as opposed to harm or death. So here's a little bit of a reality in what's going on in the United States. If we take a look at metropolitan areas versus non-metropolitan areas, put simply, there are more working poor per capita in rural areas than there are in urban areas. The infant mortality rates are higher, especially for people of color, but they're higher in rural areas than they are in urban areas. This chart really shows the effect on access to care to somebody who dies from a non-emergent, or from an emergent situation, from an unintended injury. Rural Americans, in fact, are 50% more likely to die due to unintended injury than the United States than urban Americans are. So that is an undeniable disparity in the United States. So the question I would ask you as we go in to the rest of this talk is, are these issues stemming from individual choice, or are they more systemic? And this may sound like a rhetorical question, but it's actually a literal one that I would encourage each of you to think about. I was in a presentation here in Colorado soon after I moved here, and there was a chief medical officer of a major hospital who was a subspecialist by training, and we were talking about rural health, and the man said out loud, and I quote, "The problem with rural health and rural health outcomes is that rural people aren't sophisticated enough." And I remember being floored as I heard that would we ever say that about an ethnic group? Should we ever say that about any group? Is it really that we're not sophisticated enough, or are there systems that lead to issues, that lead to decisions, that lead to health outcomes? This is a tool that I've been using. I got it from Heartland Health in St. Joseph. Another Baldrige Award-winning CEO named Lowell Cruz, who's a close friend, shared this with me, and it was adapted from a National Civic League visual 20 plus years ago. But essentially at the top of this pyramid are outcomes. Pick the outcomes, and most relevantly, think about COVID and COVID-related outcomes, COVID-related deaths, the spread of the infection, complications related to infection, those types of things. That's an outcome. In the middle of the pyramid are decisions that lead to outcomes. Those are human behaviors that lead to outcomes. Whether we smoke, how we manage our eating and our activity. Do we take in substances that may not be helpful for us? Do we wear our seatbelts? Those are decisions that lead to outcomes. In case of COVID, do we wear a mask? Are we willing to socially distance? Are we willing to wash our hands? Do we have it? Is it possible to socially distance where we are? And that gets down to the root causes, or the human conditions, which are the factors that lead to the decisions that lead to health outcomes. So freeze this in your mind and think, okay, what if this was education? Put graduation rates at the top of the pyramid. Put academic performance at the top of the pyramid. Put college admission rates at the top of the pyramid, or something like that. Underneath that are the decisions that lead to those outcomes, whether or not, school attendance rates or homework, if we're doing homework, if we're paying attention in class, those types of things. Those are decisions that lead to the outcomes in those educational environments. And then underneath that are the root causes, be it healthcare, be it education, be it law enforcement, incarceration rates. When you back it down to the bottom of the pyramid, the factors are almost always the same. And so addressing a social determinant or a factor, the human condition, addressing one key social determinant at the bottom of this pyramid can change human behaviors that can improve outcomes in multiple sectors of society. To make this personal, I was 5'10" and a half and 185 pounds when I moved to rural Kansas to be a CEO. When I left rural Kansas, I was still 5'10" and a half, and I was 225 pounds. Was I less sophisticated during those years? A year after I've moved to Denver, I've lost 25 or 30 of those pounds, and I am back to almost my college weight. I live in a different environment. What I'm saying is that there are factors, there are structural environmental issues that lead to the decisions that people make. And for me, it was that there wasn't a single thing on a single menu other than Subway in our community. Every single restaurant's menus had not one single thing on them that were not fried, that we were an hour away from the nearest fresh vegetables. And this is the story of much of rural America. And these are things we want to keep in mind. So this is a good friend of mine named Brock Slabaugh with the National Rural Health Association. And he widely or famously at the outset of COVID said, before the pandemic, rural hospitals were struggling for survival. And COVID-19 put a spotlight on the fractures that already existed within rural communities in terms of their healthcare delivery. We already had some vulnerabilities going on that many of us in the US were ignoring or we weren't focusing on. Those things became undeniable and impossible to ignore once COVID showed up, because what were stress fractures became compound fractures. And so with that, here's a fun little intervention or innovation that happened at the outset of COVID. Angel Flight is an organization. They're a network of pilots across the country. And in our case, it was Angel Flight West that covers 12 states in the western half of the US, partnered with Project Cure to try to hack a system that addressed the disparities or the fractures within our system. Of course, an N95 a year ago or 11 months ago was worth its weight in gold. They were $10 for an N95 mask. It was wild. And we couldn't get them, but nothing said "I love you" at the time like an N95 for a nurse. And so Project Cure is a national organization that procures or finds equipment and supplies and normally sends them to hospitals in the developing world. Well, it switched its focus to its domestic base and started sending out PPE to rural hospitals. Well, Angel Flight became the vehicle that connected Project Cure Project Cure supplies with rural communities. So daily flights were going out around Colorado, delivering hundreds of thousands of pieces of PPE to rural hospitals, landing on the nearest landing strip. So that has been scaled. Now 11 or 12 states are receiving these. Weekly, these flights are still going out. So if you type in Heart for Heroes, as it's spelled out, heart number 4 heroes.org, you'll find this, and it may still be relevant for many of your hospitals as well. If you're still struggling to find PPE, there's no cost for the PPE they procure or they find for you. They just send them out on Angel Flights, and they're very, very organized about it. So that's a fun way of hacking a system to take those that are normally at the end of the line and put them at the front of the line. So back to COVID and its disparities. President Bush and the Bush Center released a video right after COVID got started, saying, let's remember that the suffering we experience as a nation does not fall evenly. And in the days to come, it will be especially important that we care in practical ways for the elderly, the ill, and the unemployed. He is talking about health disparities in a very articulate way. So here's what I would say, and I hope y'all will take this as I intend it, in love. Tolerating any disparity risks the legitimization of all disparities. We can't say that one disparity matters and the other one doesn't. If we hold these truths to be self-evident, that all people are created equal, then we must care also about geographic disparities between rural America and urban America. And ignoring those disparities harms the cause, the very crucial cause of disparities between, for example, white people and people of color, which are so important to be addressing in the United States. But addressing any disparity requires a careful strategy. So this, for those of you that are Texans, this woman is founder of the Value Institute at the University of Texas's Dell Medical School, and she was a teacher of mine in graduate school in New Hampshire. And I've relationship-wise, I've followed her down to Texas, and she's taught me some lessons that I intend to share as well. And one is that the strategy requires reverse thinking. We should start with the desired outcome and work backwards. Start with the end in mind and say, okay, so then what needs to happen for that ideal to happen? And then what needs to happen for that to happen? What needs to happen for that to happen? And back it up to where we are. And it's not as overwhelming when we look at it that way, as opposed to saying, there's the pot at the end of the rainbow and I have no path to get there. So here's what we did in Colorado to address this. We developed a workflow that looks like this, that started with the end in the mind, which is optimal health for rural Coloradans, which is essentially closing the disparity gap between rural and urban Colorado. Achieving optimal health for rural Coloradans requires monitoring outcomes of deliberate and tactical interventions fueled by training and partnerships to achieve SMART goals, specific, measurable, attainable, relevant, and timely goals, based on careful assessments of reliable information. And out of that came our workflow. This is how we were going to address this in Colorado. And put more simply, on a one-pager, we developed a vision of value-driven systems, increasing capacity, and innovative payment structures that optimize health and strengthens rural communities. And then four focus areas or priority areas that would help us get there. One being leveraging data to inform system development interventions, increasing leadership and workforce capacity, improving access to excellent and holistic care, and strengthen partnerships and collaborations. These were and are our focus areas for 3 years. So what I would say is that the strategy is really around 80% capacity building and 20% about policy. So 80% about capacity building, 20% about policy. CHA, the Colorado Hospital Association, has traditionally been a very effective advocacy organization. We know how to advance stuff or kill stuff in the legislature, right? We can do those things well. But we have to have the capacities in our rural community to actually make good use of good policy. And if your state does not have a comprehensive strategy around addressing rural-urban disparities, I highly recommend it. I live and breathe and love strategy and can see the outcome of it. I highly recommend that you get that done, so that all major entities, including the medical schools and the offices of primary care and rural health and universities and healthcare organizations, hospitals, clinics, FQHCs, are rowing in the same direction, that you're all working on the same things at the bottom of the pyramid. So important. So another quote for you. We don't have a roadmap for exactly what we're experiencing or what we're currently experiencing. This is Michelle Obama. And that in of itself can bring up feelings of anxiety, loneliness, and fear. Not to mention that we worry about feeling, the worry we feel about health and safety of our parents, children, loved ones, and financial security of so many families. This is an empathetic statement, but what she's saying is that we lack a roadmap. We need a roadmap for this. And so what a colleague of mine named Lauren Hughes, now with the Farley Health Policy Center in Denver, but what I was actually formerly with the Pennsylvania Rural Health Office, worked for the state and designed and ran the Pennsylvania Rural Health Model under a CMMI innovation project. She and I got together as principal investigators and spent 5 or 6 months doing research, interviewing rural leaders, board members, hospital CEOs, primary care providers, public health leaders, patients, and looking over about 200 resources, mostly gray literature because there wasn't a lot in the peer-reviewed lit space at the time that we were doing this. This is all on the run, to develop a capacity building tool called a rural post-COVID playbook. We called it Reimagining Leadership, a pathway for rural health to thrive in a COVID-19 world. But really, this is as relevant post-COVID as it is in the current situation that we're facing. So if you're looking for a copy of this, it's online. If you type in Rural COVID Playbook, it'll come up. It's on the Colorado Hospital Association website. You can click on it. It's free. It was funded by Zoma Foundation and with a very generous donation, also contribution from CPSI, which is an electronic medical record company. Neither of them affected the content. They just funded the work. So in this, we feature 2 cases that are very realistic, fictitious cases that essentially summarize the stories that we heard in the communities where we interviewed. And we Angel Flight or the Civil Air Patrol flew us out to those communities to do these interviews on site and spend time with folks. And so We built out these cases with characters, realistic characters, that if you read these cases, they're short, straightforward, to the point. They're built so that you can take them into your own leadership teams, sit down, read those cases, and solve problems in 9 key areas. But first, before we get to the challenge areas, there is a care delivery assessment tool that it's brief. It's 8 or 10 pages, but it's mostly a template. You just fill in the blanks, but it really can help you. They're open-ended questions. It's not quantitative, it's qualitative, and it allows you to really take a look in the mirror and take a look at yourself with regard to leadership and governance, with regard to finances, with regard to community engagement, emergency preparedness, clinical quality improvement. These sections, it allows you to take a look at these areas. And we can't know where we're going unless we know where we are. So in Colorado, we're in the process of getting a capacity assessment tool done on every hospital and hopefully many of the clinics in the state. We're going to compile that data and hand that to health funders, because we believe the story of Colorado is the story of America. We've got many different versions of rural. We've got the plains, we've got the mountains, we've got resort communities. And so if we can paint a picture of rural America through these assessments and the capacities of our healthcare delivery systems, we can funders, the feds, the state, we as an association can use that to modify our strategy moving forward. So these are the 9 chapters, the 9 challenge areas that we found were most relevant to rural leaders in COVID and post-COVID. One is clinical care, one is communication, one's community, one's cross-system collaboration, and then there's space, spending, staffing, statistics, and surveillance and supply. So we call them the 4 C's and the 5 S's. And we have built in structured content in each of these challenge areas that can be helpful to folks like you on this call. And again, this resource, which I see Cassidy has just posted in the chat, is free to anyone who wants it. Feel free to use it. Please don't feel the need to read this playbook, all 134 pages from front to back. It's not designed that way. It's topical. So you can go to the area that's snagging you and go from there. So each of these areas include best practices. They include pearls from your peers. They include strategic questions. Essentially, the theme is, have you thought about ... Because we know that this is a playbook that is written with the understanding that a playbook in this situation is impossible. There is no list of links that you can go to solve your problems. This involves critical thinking, and we believe that our rural leaders in our healthcare delivery systems have the intellect to do this and would benefit from additional tools, and that's what these tools are about. So they were developed through the lit reviews. They were developed through key informant interviews and an analysis of all available resources. So I'm going to give you some nuggets that come away from this, and then we're gonna have a discussion around some reflections on how COVID is affecting you. So here are some nuggets that we pulled away from this from these interviews and that we inserted into the playbook. Under clinical care, we heard folks that were expanding their provider to provider work through telehealth. Of course, we all know that COVID blew telehealth wide open in a tragic and beautiful way. It shoved us into doing the right thing. We were able to tap into free education like we couldn't previously, or make free education through telecommunications a priority. We were able to bring back the home visits from 100 years ago with doctors with little black bags going into homes, and nurse practitioners the same way, and PAs were able to do that. And we were able to move as much care as possible actually into patients' cars. This was a trend that we saw, because their cars are a contained area, and sometimes they don't need to get out of their car to receive care, and it keeps everybody safer that way. It was a way of hacking the space thing too. Under communications, we heard that a best practice was to plan all crisis communications in advance. So the first COVID diagnosis, the first COVID hospitalization, the first COVID death, the first staph diagnosis, the passing of a unthinkable, but the passing of a healthcare worker. All of those things were written into crisis communications in advance. Those were pre-written so that they could be released in a timely way and less reactive, more proactive. Hosting Facebook Live press conferences, not just Facebook, but other online social media platforms. Filming COVID-19 survivor videos. So this is it's been really controversial. First, the masking piece, and then also the the vaccine piece, getting people that were really sick or who had lost a family member who were really whose values align with the values of a community to get on a video and have the courage to say, I didn't take this seriously, I now do. Get the shot. Get your vaccine, wear your mask, watch your distance, wash your hands, do the right thing. We didn't take it seriously. This is what happened. So finding people that had the courage to say that type of thing, getting them on videos has a powerful effect locally, much better than the governor making an executive order or whatever, something like that. Somebody coming in from the outside, doing it internally and expending the few $1,000s it takes, if it even takes that much, to get a good video done. And then host standing daily Zoom meetings across all levels of organizations or of community leadership to keep community folks going. So as surges reemerge, these are some best practices for communication. Under community, we found communities that were, several of them, that were giving away prizes if somebody was caught wearing a mask in public, especially in places where adhering to mask mandates were really challenging. If somebody's willing to do that, here's $100 in chamber dollars, go spend it at a local grocery store. Word in a rural community spreads like wildfire when that's going on. And so at very least, folks keep a mask with them for the chance that they'd be seen, right? And so that was a kind of a carrot, not a stick innovation. Establishing a mutual aid society or community resource online, some group support was another one. Distributing lists of available Wi-Fi, especially as broadband issues still are very, very prevalent in rural America. Establishing places where kids could access online education if schools were shut down was also helpful, or accessing care that way. And then asking teachers to run programming to help healthcare workers was another one. Under cross-system collaboration, traditional incident command teams that were focused on innovation. So we had somebody put something out. One of the hospital's CEOs literally put out an email, said, if anybody's ever called you MacGyver, please come to my office today. We need you. And she essentially put unsolved problems in front of this group of innovators, which were everybody from housekeeping and maintenance folks to senior administrators or nurses, frontline workers, CNAs, and said, please hack this system and figure out how to solve this. And she said she was blown away by the innovations they came and how innovative her rural team could be. Infection control and PPE nursing home strike teams to really manage infection control in a new and effective way that will likely have implications after COVID. School and business partnerships for contact tracing. People trust schools, people trust their local businesses. They can help certainly more than somebody from the state around contact tracing. And then independent providers and staff alternative care sites as well. Under space, there were a couple of things. People set up donning and doffing stations using curtains, using what they had. They didn't need an architect to help them figure that out. They were able to figure it out. They used shower curtains, PVC pipes. They just hacked stuff so that they could get it done. Alternative care sites. They used fairgrounds, community colleges, hockey rinks, whatever they had available to administer vaccines, to set up screening sites, things like that. Visiting specialist clinics becoming available, being replaced by temporary respiratory clinics because specialists weren't flying, and those clinics continue to wax and wane. So repurposing that space was another. Under spending, the lesson learned was apply for everything, even if you don't think you qualify, because we don't know what's coming in the future. We don't know what's going to be forgiven. So those that didn't apply wish they had, and those who did were glad they did. And so, but also networking between sites to figure out, somebody in a rural region is going to get really good at these applications. Let's pay that person to apply for all of us. And so that came up as well. Devise new sources of revenue, screening for local businesses. So there was some funding that local foundations were able to leverage to engage local businesses that were struggling to set up screening sites that helped sustain their local businesses, but repurposed them while restaurants were slower down or things like that. Engaging volunteers or law enforcement to decrease lab courier fees as well. If we've got folks that aren't doing work, what can we do to get them to do work for multiple benefits? Under staffing, under staffing, we were just repurposing people. What was the theme? engaging medical students to write grants. They were looking for clinical rotations, couldn't find meaningful work, getting them to do something that was meaningful. If they have the capacity to do it, let's use it and let's repurpose people. Under statistics and surveillance, leveraging relationships with academic centers to get results faster and to preserve PPE. Academic centers in Colorado, we've redefined the rural-urban relationship. For not just for statistics and surveillance, but beyond that, that was also helpful. And then under supplies, we had folks starting in-house PPE workshops, like line workers, folks that would have otherwise been furloughed. We're turning out PPE, doing meaningful work and contributing to the solution, which was actually helpful to employee satisfaction scores, things like that. Buy syringes early, buy the stuff that you need before you need it, so that you're not fighting with everybody else when you actually need it. So some rural hospitals were saying, we know we're at the end of the supply line, we're going to get ahead of it now so that we don't end up up a creek down the way. And then exploiting all rural supply chains, not just healthcare, but hardware or trades organizations, or auto industry, or veterinary stuff, or agriculture, hardware store, all those areas. Look everywhere for what you need. Don't just look in your traditional channels. Out of the box, and then create portable PPE carts and appoint PPE czars. So within organizations, some of the strongest ones had locked up a complete PPE cart that would be enough to cover all staff for one shift, locked it up in the med room where only one person or the charge nurse or the supervisor, the house supervisor, would have access to it, so that every nurse could know, I'm going to be covered on this shift. Every staff member could know, I'm gonna be covered on this shift, because PPE, there was thieving that was going on. It was really complex. So then, kind of as we round this out, we also got some advice on what people would do differently. And one is maintain stronger relationships with urban and academic facilities. Those relationships that were strong were hugely beneficial. Those that were not, people found them needing to build them on the fly, which happened many times, but it was more difficult in the middle of the crisis. But maintain stronger relationships. They wish they would have done that. Frame guidance in terms of what one can do instead of focusing on what we can't do. Operate from a place or a mentality of abundance rather than scarcity. Focus on hacking and problem solving. Prioritize planning for the most vulnerable first. In nursing home, residents came up over and over. Nursing home staff didn't have PPE, which put residents at risk. And so they're often forgotten. So making sure that folks in vulnerable groups are given a priority. Exploring regional strategy for staff supply spending. So certain communities 30 miles away from others are experiencing surges while the other ones are slow. Really regionalizing and figuring out an efficient way to share nurses, share staff, because that has just rippling implications around how organizations can collaborate together when they start building relationships at a frontline level. And so we found folks doing that, but wishing they would have done it more. Thinking infectious disease in the remodels, new construction. So many of us are still in Hilberton hospitals with boilers that are about to explode. I mean, I was a CEO of one of those places that had to eventually be replaced. And thinking about infectious disease as we redesign space. One of my favorite innovators around this is a group called Mass Design Group, MASS Design Group. And they're a global nonprofit that they're based out of Boston, but they really hack systems and they're interested in rural work. And they think about things entirely differently than a traditional architect. And so thinking about how disease can be contained instead of spread, or healing instead of harm, in the design of space. They wish they would have done that more ahead of time. Incorporating rural philanthropy in the recovery phase. Philanthropy, there's a huge opportunity even now as COVID has done very well for a certain population of people. And those people, many of them are philanthropic. And so how can we engage them in solving some of these problems? This is to those that have really found themselves financially improved during this last year. Cross-training staff at all times. It's always been a good practice. It's now life or death. We need to do this, be better at it. And then transitioning to multi-use PPE and sanitizing PPE is another thing that they wish they would have done differently and earlier. So, how can an individual organization begin to develop strategies that address disparities in a post COVID-19 world? Here is a tool to take away with you, something hopefully to do different on a Wednesday morning or next Monday morning, or however you look at it. It's a 6-question tool that I've been using for most of my career, and it's simple. And it's, let's start with one thing. Pick one meaningful thing that needs to be addressed. What outcome needs improvement? Who are the stakeholders? Where are there opportunities to share? Why isn't it already happening? How do we measure its success? When do we expect to see progress? So when you think about what outcome needs improvement, take what you're already measuring. This is a radical challenge. Take what you're already measuring and divide it by people group and see if you find disparities. And if you do, then stop, ask, are we okay with this? Are we okay that a Black woman is more than 4 times as likely to die in the United States due to unintended injury than a white woman in a different neighborhood? Are we okay that a rural American is 50% more likely to die due to unintended injury? These are big problems, but take it down to a granular level at your organization. Say, what clinical outcome, what organizational outcome, what financial outcome, what stewardship outcome needs improvement? And let's take a look at it, and when possible, divide that by people group. Who are the stakeholders? Think about all the groups of people that would care about that outcome for whatever different reasons. Think about them and then ask, what can they share? Consider unlikely contributions from unlikely sources. So sometimes it's people that we're not even tapping that may have exactly what we need. They don't have to have an acronym that starts with C after their name to be a stakeholder. They can be a frontline worker, they can be a housekeeper, they can be a community member, they could be a widowed woman living in her home alone who has capacity and needs purpose. It could be any number. Why isn't it already happening? Perhaps one of the most important questions. If we don't think about this, whether it's a tactical issue or an adaptive issue, whether it's a capacity issue or a policy issue, can it be hacked or retooled? Let's think about why isn't it already happening. Let's not overlook anything, or we're going to run into a snag when we try to implement a strategy. Ensure the impact is measurable. Ensure that it's measurable so you know you got it done. Build out a timeline, set a deadline, and get it done. Feel free to take a screenshot of this and implement it in your own organizations. So now I say this as we wrap around to conclude. What's next for us? And how do we think that has implications on others around the country? We've partnered with Scott and Elizabeth at the University of Texas's Dell Med School to begin to write rural cases and write and publish them. They're teaching some of these cases in their Master of Science in Healthcare Transformation program, which is a virtual program, giving rural and urban leaders transformational skills to develop systems that lead to better quality, to lead to better outcomes. But it's a master's focused on healthcare value. So they're writing cases with us, and we are able to teach those cases that are really written so that a board member of a rural hospital can understand them, so that a frontline worker can understand them. And so we built out, one's on governance, one's on maternal care, maternal health outcomes. So teaching that case. One is on value-based healthcare. On Aspen Valley Hospital. It was written by the Tuck School of Business at Dartmouth. This is a rural specific case focused on value post-COVID here in the United States. And we have access to these cases and are teaching them actively in Colorado. And then one is on the merger of 2 small hospitals to make a small system where there wasn't a big system that came in and enveloped that hospital and all that goes on with that. It was 2 small hospitals that chose to trust each other. And we're teaching how that went down, how it happened. So that's where we're taking capacity building next. So again, where it goes back to is we're implementing the rural capacity assessment system, developing a baseline of where we are. And I bring this back at the end of this to the rural strategy, which is all of these sections are touched of our rural strategy during COVID. We didn't have to shelf our strategy during COVID. It became all the more important. This is why it's so important to have a statewide or system-wide or organization-wide strategy that keeps people rowing in the same direction so we can check this stuff off and get it done and be able to measure it. So here's some key leadership lessons and takeaways. How do we align priorities? As leaders, we got to serve as a North Star. We have to have an unwavering conscience on the right thing to do for people who are voiceless, especially those who are voiceless who are trusting us to be the experts. Two, why did it take a crisis to get here? COVID highlighted and exploited the hairline fractures in our system that are unignorable, if that's a word, that are impossible now to ignore. Where are the solutions? We got to listen to the people on the front line. We got to listen to the people who know best, and they are not the people whose job titles are C-level. They're the people who are in the trenches working along folks. And lastly, is collaboration required or simply a best practice? Eesh, people die if we don't do this stuff together. They die if we don't. So there's what's at stake. So I would say this in closing. Why is this world, or why is this work so important now? Not just in COVID, but after COVID. It's because there are millions of little boys like this one who doesn't know what's going on in his brain, but something's going on. There are millions of patients who are vulnerable, who don't know what's going on, can't control their outcome by themselves, then they need help. They need systems that lead. And so when that can lead us to that end. And so when David asks me, Daddy, can I beat Goliath? I can say, yes, you can. And there are legions of people behind you that are backing you up, that are helping you. And in our family, there are spiritual implications to that story, but there are also some practical implications too. There are millions of people that are counting on us to hack this stuff and solve these problems so that they can experience life and liberty and the pursuit of happiness in rural America. And my final closing thought as we get into questions is it's just a reflection. I was visiting with my wife, who's a counselor by training, and her passion is rural America and helping rural families, rural marriages, and I think a conclusion we've come to after this just exhausting year, coming after what has been an exhausting decade, is that exhaustion is the silent thief of empathy. Sustained exhaustion siphons empathy from the human soul. And at some point when we become so tired, we cease to feel the suffering. We cease to feel the suffering of other people. And that's a dangerous place to be in healthcare. And I want to speak to the souls of the folks that are on this call to say, if this is you, I just want to acknowledge that breathing exercises may not be all that's needed. Mindfulness exercises, maybe not all that's needed. It may not just be you don't have the right work-life balance, or you just need a vacation. We so often want to think about exhaustion as an individual problem of the person who's experiencing burnout. There are systems that lead to burnout and systems that lead to healing. And so we can apply that same 6-question tool to solving that too. And so if you are in a position of influence, we can engage frontline folks to solve that just as well as we can any other health issue. The work you're doing is heroic. The work you're doing is important. The work you're doing is vital for people that will never know you're doing it. And behind the scenes, when you are not appreciated by the very people that you're trying to serve, just know that there's a greater purpose in that, and that the work is valued and it's worth it. And so thank you so much for listening. I'm happy to take some questions in our last 10 minutes or so.
Wow, thank you, Benjamin. That was excellent. And I think I speak for everyone on the call based on the comments that was really, really incredible. We do have a couple of questions that came in to me personally. And while I go through those, I would encourage you to type your questions into the chat box. If you do not want to ask your question to everyone, you can just select my name from that drop-down box, Cassidy Avila, and I would be happy to ask a question on your behalf if you would prefer to do it that way. So you've got a few minutes to gather your thoughts and type your question, and I will grab the questions that came to me personally. Benjamin, the first question states, how do you tackle some of the data mining issues to look at quality when you have limited staff, or more often limited technology that can't look at some of the information that seems necessary?
I'm curious, and maybe we won't know this, but I'm curious what state that's coming from, because different states have different resources. I can tell you the answer for Colorado. And we should talk offline about how maybe there's some ways to help. We have statute driven data that is, we've got financial data, and we've got um, claims data that we use at the association to make decisions. And we have a rural dashboard for every rural hospital and a rural healthcare delivery system in our state, where we can show them this simple dashboard and how to access what's going on within their community, what's leaving their community, what's staying, and then also they can use some of that data to um, to make decisions. So it's really a decision support tool. So that's how we do it in Colorado. I think if we don't prioritize this within our organizations and dedicate somebody in an organization to be the data person, and not having the fifth or sixth or 10th hat, we've got to dedicate somebody and see the value in this, to do it. And often that data person can identify inefficiencies in the system that can pay for themselves, that can allow us to repurpose people, for example, so that we're not necessarily adding FTEs, but we're repurposing FTEs. But so often in rural healthcare delivery systems, we're making decisions without adequate information, and so we're just guessing. And when we guess, we waste. And when we guess, we sometimes harm. And so it's really important that we dedicate somebody to knowing and understanding that data. There are certainly training systems that are out there. I think partnering with academic centers around that kind of data training, because they have training within their systems, is often a way to get that person trained without a significant, if any, expense. So that's one. I would be happy to take a personal email though from the person that asked that question, and I will type my email into this email box here, so they can shoot, and hopefully I can connect them with some resources as well.
Thank you, Benjamin. And that question came out of Nevada.
Okay. Well, my family's in just outside Reno in Truckee, California, so I got a soft spot for Nevada for sure.
Well, great. Then I hope you guys can make a connection. I'm sure they would appreciate it. And our next question states, what are some recommendations or examples for how rural healthcare can better engage across all sectors, for example, education, church, economic development, etc.?
So that's a great question. I mean, I just want to hug whoever asked that. That's wonderful. At a local level, it can start with healthcare and schools and churches, those three. So we would get together when I was a CEO every year with the school system. We would sit down in a room with the school board, the hospital board, and the leadership in both of those, and then bring pastors in as the third leg of that stool and say, what kind of shape are our kids in? I mean, kids are the heartbeat of a community. So let's start there. And that's how we built the infrastructure, was because we all loved our kids and we wanted them to be healthy. So we started there, and we'd have an annual strategy session around addressing the bottom rung of the pyramid for kids. And then once we built that out, we had the infrastructure to address stuff among the aging population and other groups within our system. So, or in our community. So it can start with kids. It starts with schools in a rural community, schools and hospitals and churches. And often churches are not used to being brought into those conversations, and are really grateful when pastors are included, because for some reason we separate a person's spiritual being in the United States from their physical health. And in a rural community, churches are a backbone. And so when we engage pastors to help solve problems, they have insight. I mean, there's so many of them are treated like counselors with no formal training in that. They see this stuff and just don't know where to go with it. So when we can pull them in to the discussion, it's great. But I think it's starting at a local level. That's where we begin.
Excellent. Thank you. Okay, so those are all the questions that I had personally. Okay, one more just popped through. What are some strategies for engaging survivors of family violence who are seeking rural health care? How can local domestic violence programs make connections with healthcare providers during this time?
I think it starts with leadership having conversations with each other, and those relationships are really crucial. When I was in Kansas, we set up a mobile program I was in Lakin, and there was a group out of Scott City called the Western Kansas Child Advocacy Center. And we actually set up a mobile program where our nurses were trained as sexual assault screening nurses, and would actually go out and cover about 30 counties in Western Kansas with sexual assault screenings when something had happened, because so often when somebody is hurt like that, access to screening in a timely way is missing. And by the time you can get access to that screening, the damage is gone, or it's no longer credible. And it's a lot harder to prosecute if you don't get quick screening. So we actually set something like that up, but it began with us just sitting down and having a conversation saying, what outcome needs improvement? Well, we need access to these screenings for rural kids and rural women. Okay, so which stakeholders are involved? What are their opportunities to share resources? Why isn't it already happening? How do we measure its success? When do we expect to see progress? And we deployed that, and out of that came a federally funded solution that was screening folks around the state, in a mobile RV clinic that would show up in their community next day, and would be able to screen those kids. So we can solve these problems if we just get together and use a structure to develop a strategy around it. That's a great question. I'm so glad somebody's thinking about marrying healthcare and social services. They're so important.
Excellent. The next question states, briefly speak to COVID vaccination. What is the plan to reach rural?
I'm actually on a COVID. So Harvard Center for Primary Care emailed me 3 or 4 weeks ago and said, we're developing a 10-week what we call a vaccine sprint, or a 10-week, almost like Project Echo, a virtual education project that is really going to analyze this, build the car as we're going. And we really want to make sure rural's perspective is built into this. And we're going to take some key learnings out of this and develop some cases that we can take into communities as well, teaching cases. But we're looking for folks that want to log in for this, and they're securing grants so that it doesn't cost rural systems anything to be involved except their time. But it's a 10 1-hour session per week, or one hour session per week for 10 weeks studies on how this is going, but it's active discussion. If any of you would like to be involved in that, shoot me an email, because we're really talking about that as we're going. Out of that's going to come a playbook, some learnings, but we're learning as we're going. So it's going to start early March and go for essentially 10 weeks. And so we're actively looking at vaccine equity in rural communities as well, and bringing those best practices together. So if any of you have interest in that, I'd be happy to connect you with our friends at Harvard.
Great. And Benjamin, I'm looking through the chat. I know you said you would share your email, but I didn't see it come through. I'm happy to share it.
Oh, I just shared it with one person individually on accident.
Oh, that's fine. That is fine.
I'll share it with everybody now. Here you go. All right.
Sorry to put you on the spot.
No, thank you. It was an oversight on my part. I just shared it.
Perfect. Great. Thank you.
I would love to know if there's any takeaways from an audience member who wants to speak up. You could do it in the chat or unmute or whatever. I'd love to know what you do differently on Monday morning.
Yeah, if you're struggling to unmute, just let me know in the chat and I will unmute you.
Being with you all is a privilege. I got to see not necessarily the audience attendance list, but I got to see where all of you are from, the different states and different roles. And what a privilege to be in front of you and to share this time with you.
Okay, Benjamin, we did get another question. Are you okay to continue on with us? I know it's past 1.
I can go.
Another minute, great.
Yeah.
This question states, how can we as county public health employees convince those in our community who may have a distrust of the government and in turn the COVID vaccine?
So when I spent 10 years in rural Kansas, I think a lesson that I learned the hard way was that people will choose relationships even over logic. And I don't think that's just rural. I think that's people. People will choose relationships even over logic. Something may make total logical sense, but if a rural community member doesn't trust the person with the message, it isn't going to go anywhere. So I think it's so important to think through, how can local relationships be utilized, be leveraged to make the right thing easy or to make the wrong thing difficult. I mean, that's how we change human behaviors. We make the right thing easy and make the wrong thing difficult. You got to do both. I mean, that requires relationships. And so it requires people, again, leaders, but leaders don't have to have a title with them. It could be a home health aide that knows the most vulnerable people in a community that wouldn't otherwise get vaccinated because they're scared of it or caught up in a conspiracy theory or something. But if Haley, the home health nurse or home health aide who bathes these people, is going into their house saying, "I love you. I've done the research. This stuff's real, and this can really help you. And because I love you, I'm asking you to take this." More often than not, people receive that in love, and they say, "Okay, I trust you. I don't know anything about these fancy people at CDC, but I know you. And if you say it is, and I'm okay with it, then I'll do it." So I think it comes down to leveraging relationships. And I mentioned the videos earlier. I mean, it's really important that that be scaled, especially in larger rural communities, because there's not enough capacity to have those conversations individually. Then let's get those people on video, leveraging their credibility, leveraging their trust in their community. And I know that's hard. We've had one CEO posted on. She had a lot of local credibility. She posted on Facebook, "Our hospital's full. We're experiencing a surge. Please adhere to the mask mandate." And somebody responded accusing her of fear mongering and saying she should be lynched. I mean, I'd love to say that's out, like that's uncommon. That's common. That's going on in rural Colorado. That's going on in rural America. Public health leaders being run out of town. This takes courage to do, but as leaders, we need to have the courage to do it, even if it strains our relationships, even if it costs us personally. That's what leadership's about.
Wow, and we've got a lot of comments in the chat asking about getting a link to this recording, and I do want to let you know that we are recording, and we'll share a link to our website, and you can share this recording with anyone you like. It will be publicly available. We had another question in the chat that states, regarding the COVID vaccine in rural areas, we are having an issue getting individuals logged into the system to get signed up for the vaccine. Do you have any suggestions on other ways to get them signed up for the vaccine in rural areas? Some older individuals don't have access to internet or don't understand the system.
A couple of things. It depends on the state, right? So every state's different. Colorado, we're very fortunate to be in a place that's, I think, as organized as we are about it. We have weekly access to the governor. Like, we get on a call with him every week and what issues are going on. And so the state's been very supportive. And so we've been very blessed that way. I mean, some states are turning vaccine distribution over to an insurance company, right? Or somebody else, because they haven't been able to effectively manage it. And it's difficult to know how to do that. And it's also varies widely in states. Are they the healthcare providers that are administering them? Are they LPHAs? And so I think if it's a healthcare person that's asking the question, there are people, while certain volumes are down in healthcare systems, that have capacity that can be leveraged to be helpful. But I think having meaningful conversations with local public health organizations or the LPHAs, or the folks that are administering the vaccine, saying, what can we do to make the right thing easier? What can we do to remove barriers? And if that is going into somebody's home, I mean, every time a vulnerable person gets a shot in the arm like this, that's a win. In rural communities, just a few dozen people, 100 people make a big difference. So I think taking the care, taking the sign up process, taking that type of thing to people is the way to go, and figuring out which stakeholders have the capacity to do that. And sometimes they're not even working in a healthcare organization or LPHA. There are other folks that are at home who have been vaccinated, who feel comfortable going out and helping their friends at that point. So engaging volunteers.
Excellent. And someone else commented in response to that last question, in our community, patients can call any healthcare provider in the county for help filling out the form. The county health department then coordinates the distribution.
If only every community functioned that way. It'd be great. Thank you, Tamara.
Okay, so we are about 10 minutes past. So I'm going to go ahead and and say my goodbyes. But if you have questions that you did not have time to type into the chat, please just email us or email Benjamin, and we would be happy to do our best effort to get a response for you. But I can't thank you enough for joining us today. And Benjamin, huge thank you to you and kudos for an excellent presentation. It was very well received, and we were so happy to have had you on the webinar with us today. So thank you to everyone.
Thank you very much, and I welcome emails from any of you. If I can be helpful to you or connect you, happy to take them.
Great, thank you so much. And look for the email that we will be sending out likely tomorrow once we get the webinar posted to the site, and you can pull down the recording and share it as you like. I also posted a quick 60-second survey if you have a moment. That will also be in the email. So thank you so much for your time today. Have a wonderful afternoon, everyone.